All right, good morning or good afternoon, wherever you may be. Thank you so much for being with us today. I can see more and more people are continuing to arrive, which is really exciting. I'm Grace Rubenstein. I'm Editorial and Communications Director at Health Begins, and welcome to today's webinar on frontline lessons for addressing social needs through Medicaid. You're going to hear a lot of direct experience from California's Medicaid transformation today. So next slide, please. Just as we get going here, a little bit of housekeeping. Um, this webinar is being recorded. We will be sending all the participants and registrants the recording as well as the presentation slides after the webinar. All of your lines as participants are on mute for the duration of the webinar, but if we really care about making this an interactive, lively discussion, we consider it kind of a community meeting. And so if you have a question for us, you can enter that at any time into the chat window. We'll be monitoring the chat throughout. And we have reserved time at the end of the webinar to answer as many questions as we can. We also find that often folks who are participants are sharing resources with each other in the chat while the presentation goes on, and we love to see that. So feel free to help each other out there as well. Let's just warm up a little bit and make sure the chat's working for everybody. If you open the chat window, go ahead and send a message. Make sure it's set to send to everyone, just saying your name and where you're joining us from. Here's a little demonstration from me. Let's take a look. Melissa, Dan, Emily, Cassidy, Alberta, Meryl, wonderful. We have folks from all over the place, and we're so happy to share these lessons with you today. So this is a 1-hour presentation. We ask that everybody bring respect and curiosity and joy to the discussion that we're going to have today to make it as fruitful as it can be. Next slide. So our objectives for today are 3. They're to describe the essential features of California's Medicaid transformation model. That's the foundation of what we're discussing. 2, identify common implementation challenges and potential solutions. And 3, explain best practices for establishing successful referral systems and sustainable CBO partnerships, because we want these innovations to last. Next slide. With that, it is my honor to turn it over to Health Begin's own Senior Program Manager, who has been hands-on and knee-deep in all the metaphors into this work in California, the one and only Alexis Taylor.
Thank you so incredibly much, Grace, and I am here for all of the metaphors. You are so appreciated. I'm so happy to be here and share space with everyone that's here today. Really to learn these frontline lessons, as Grace referenced earlier. The entire nation has been watching California for the past couple of years, really to understand what is Medicaid transformation, what are the lessons that are coming out of that work, and how can we take those lessons back to our organizations, both within and outside of the state. And so with that being said, I'm super excited to be here, and I'm even more glad to introduce our power panel for today. And so if we go to the next slide, I really want to call out the diversity of thought and experience that we're going to discuss or we're going to hear from today. First, I'm going to reference John Cisneros. He is a clinic manager and the director of community engagement at San Joaquin Health Centers, and he is going to provide the FQHC and provider perspective, for today's conversation. Next, we're going to hear from Nye Kasich, who is a health systems consultant and a former vice president of Medi-Cal programs and HealthNet. So she's going to bring the MCP, the managed care perspective of navigating Medicaid transformation. And lastly, we're going to hear from Terry White, who is the Director of Community Supports and Enhanced Care Management at Turning Point Community Programs, who is a community-based organization and also provider of CalAIM services. So this is our power panel that we're going to hear from later on in the conversation. If we go to the next slide, I also wanted to share a bit about who Health Begins is. We are a national mission-driven strategy and implementation firm, and we help Medicaid serving health plans, health systems, and community-based organizations to not only meet, but to exceed health equity and social needs requirements in order to achieve long-term impact for people and communities that have been harmed by societal practices. And for more information on our work, we're going to include a link to our annual report. We've also included a little bit of data on this slide. If we go to the next slide. Before we dive in, I also think it's important for us to uplift why it's so important for us to move upstream as we develop interventions that work to advance health equity. At Health Begins, we ground ourselves in 5 observations. First, health and social inequities are experienced as harm. Next, social arrangements, including structural racism, put people in harm's way. We also understand that equity is not just the absence of harm, it is the presence of systems that promote healing, opportunity, and justice. And since structural violence and harm is spatialized, institutions need a portfolio of strategies to advance health and social equity that is place-based, outcomes focused, and works across multiple levels of change. And finally, courageous leaders need support and solidarity to implement these strategies and to transform their institutions, their relationships, their communities, and themselves in the process. And so today, some of the courageous leaders that we have worked with are going to share their efforts and insights to advance health equity with the hopes of equipping your teams with the knowledge and insights to make lasting transformative change. That being said, I'd like to dive into a little bit of level setting. So with level setting, the question I want us to consider is, what is Medi-Cal transformation, also known as CalAIM? So Medi-Cal transformation is a long-term commitment to transform healthcare by offering a more equitable, coordinated, and person-centered approach to improving population health. According to the Department of Healthcare Services, or DHCS, CalAIM breaks the mold of traditional healthcare systems, and its success is going to be a model for transforming the entire healthcare sector. Like I stated at the top of the call, we're all watching California, trying to figure out, is this model going to work? How has it worked to advance equity? How can it be replicated in other states? And so today, using the experience of the diverse stakeholders I referenced earlier at FQHC, a member of a managed care plan, a community-based organization, we're going to speak to what we've learned and whether or not these lessons and these transformations have the potential to be modeled. That being said, I'm excited to go into the next slide so we can dive into our first panelist. The first part of our agenda for today is going to discuss programs and initiatives. And with that level setting in mind, I'd like to get started by asking Nye Kasich to help us understand the context of CalAIM. So Nye, can you please share a little bit more about the goals of CalAIM? What makes this expansion of services so important? And particularly, why is this important for health equity? And I'm happy to kick it off to Nye.
Yeah, no, thank you so much for that introduction, Alexis. I'm going to try really hard to not use acronyms because I know that it's so easy to kind of do that in healthcare. So I just want to call out that California Advancing an Innovative Medi-Cal program and initiative began in January of 2022. So we have a couple of years of experience under our belt, but certainly we're still learning as we're evolving and as the program is further expanding. And in regards to the transformation, the California transformation that we're undertaking, the California Department of Healthcare Services has defined 4 separate goals. One is to address physical and mental health needs. Second, improve and integrate care. Next is catalyze equity and justice. And finally, work together to build healthier state. So what does it mean to address physical and mental health needs? Well, this is really to implement services that address both health and health-related services, such as housing support as an example. But California has taken a particular focus and interest in integrating the provision and coordination of behavioral health services, along with medical care services. Traditionally, our state has put those 2 provider or care types into 2 different buckets. And we have an opportunity here through this initiative to integrate the 2 and to really call out those diagnosed with serious mental illness and substance use disorder to be receiving services at an individual level. Now, how does this really translate for, again, individuals and how they access services? Well, through this program, the goal here is to really make it simple for Medicaid eligible individuals to access services. The services are standardized and the processes are streamlined across the state to, again, to address and improve individual health outcomes. And what Alexis mentioned earlier in regards to equity and justice, well, this really is the building block of California and its goal, and really to address equity across the entire state, regardless of your ethnicity, your gender, sexual orientation, disability, immigration status, age, or health needs. And the way we're going to accomplish this is by working together. And in order to do this, the state has really broadened the network of partners or providers. So this includes not only managed care organizations, but the contracted providers that work with managed care, along with community-based organizations. These agencies have been providing social services and other services for many, many years and decades for Medicaid eligible individuals. Now they're considered partners or contracted providers, broadening the definition of provider types. And I just want to call out the other things that the state and managed care organizations are working on is to contract with agencies or organizations that provide community health worker benefits and doula services. And again, these are critical components to providing whole person care perspective. If we go into the next slide, I want to talk about the components of the Medicaid transformation. I want to call out two main components. That's community support and enhanced care services. Those are the first two bullets. Community support are the wraparound social services that is going to impact an individual's health outcome. So some examples include housing navigation, housing deposit, sustained tenancy. There's about 14 in total to which managed care organizations can elect to make available in their service area. And that's really coupled tightly with enhanced care management services. These are services that provide an intensive, complex case management services for an individual, regardless of whether it's clinical or non-clinical services. And there's a heavy emphasis on coordinating with community-based organizations that are providing the community support services. There's an opportunity for enhanced case managers to also connect our members or Medi-Cal individuals to primary care as well. And typically, and unfortunately, in managed care, Medi-Cal members typically don't interact with primary care to receive preventative care services. And so, again, this individual, the enhanced case manager, has an opportunity to be that hub to connect all the various services. Few other initiatives or programs under this initiative include behavioral health. I talked about really calling out those individuals diagnosed with serious mental illness or substance use disorder to receive both enhanced case management services and community support services. Dental care is included, along with integrating those individuals who are duly eligible for both Medicaid and Medicare benefits, making sure that there's coordination and optimizing both benefits that are available through these programs. This year in 2024, health plans and state of California is really focused on connecting justice-involved individuals, so those who are out of incarceration, to be part of enhanced case management services and community support services, along with birth equity population of focus. So these are individuals who are either pregnant or have delivered in the last 12 months, who are African Americans, Native Americans, and other indigenous groups, as well as Hawaiian natives and Pacific Islanders. And then a special emphasis on long-term care eligible beneficiaries, making sure that there's coordination of services for those individuals who are in skilled nursing facility or are needing to be transitioned out of nursing skilled facilities. And then I want to talk about the Population Health Initiative, which is fairly new. It's in the process of being executed, looking at the spectrum of preventative care to tertiary care of individuals, and then supporting children and their parents. I just want to call out the last two bullets on this slide, which are the funding opportunities. So the State Department of Healthcare Services has invested substantial funding for providers to offer these services through infrastructure building and capacity building. And the two different funding avenues are providing access and transformation health path cited funds, or incentive payment program that's available from each of the managed care organizations. I'm going to take us to the next slide and really dive in a little deeper around the two main or core programs, and that's community support services and enhanced care management services. And really, the opportunity here is to provide whole person care perspective services. So for community support, these are, again, the wraparound services that's supposed to help individuals' social needs to improve their health outcomes. So some of the ones mentioned here, including housing deposit, housing navigation, housing transition, medically tailored meals, short-term post-hospitalization housing. I'm going to call out a few others that are also on the state website, include recuperative care services, asthma remediation services, personal care services. And so, as you can see, there's a broad range of social services that are available. And then in regards to the enhanced case management services or ECM services, again, this is really the complex needs coordination of services for the high-risk population. So those individuals who are diagnosed with serious mental health or illness, substance use disorder individuals, adults and families that are experiencing homelessness, or those who are at high risk of using high level of healthcare services. And then there's, again, an emphasis of serving those who are part of the justice involved community, or those who are being released from incarceration. And then I just want to also call out the birth equity population, because again, there's such need to make sure that there is appropriate services and mechanisms available for those that are needing the additional support to have or to result in positive birth outcomes. All right, I'm going to pass it back to you, Alexis.
Nye, thank you so incredibly much for grounding us and providing all of that context and foundational information so that way the audience can really understand not only the goals of CalAIM, but how Medi-Cal transformation is structured. I really appreciate how you called out that it expands the provider network to reimburse social service providers, so that way they can address not only health, but health-related needs. And Terry represents a community-based organization that has joined this network. And so I'm really excited for us to move into the next section, which we're going to discuss some of those successes. And so Terry, as a community-based organization that has joined the CalAIM network, what are the issues that CalAIM addresses? We know that, Nye uplifted all of these services, but what issues do those services address? And also talk to us about what was achieved within the first year of implementation from your perspective as a community-based organization. And Terry, I think you might be on mute. And
I apologize.
perfect. There we go. Thank you so much.
Hi, thank you. And thank you again for having me here. So the slides here are really going to show kind of the responses to the programs that we're able to provide in the community. So to understand why this works, we have to really focus in on the data. So nearly 1 in 10 Californians has a substance abuse disorder, or it could be referred to as SUD. Among the unhoused, nearly 50% have serious mental health issues or serious mental health illnesses. And Black mothers only account for 5% of pregnancies in the United States, but make up of 21% of the pregnancy-related deaths that we see in our communities. So these reflect serious challenges that people face every single day. Importantly, those impoverished situations and those historically marginalized in communities are disproportionately impacted, meaning that they may face far worse outcomes in their health. And if we could go to the next slide, what this has turned into for us and the amazing access that we've had to those in our members has been very changing in how we deliver services. So for example, and we did change the name of this member for her protection, but as you will see, the challenge was that this member suffered serious brain injury and was very much at risk of losing her housing. She was in already the legal process, and she lives in a remote rural community that was built for low-income families. And she was at risk of losing her housing due to the behaviors that she was experiencing in linkage to the anxiety of losing her home that she had been in. And so the solution is that she was referred to us by a community partner that provides legal services. We started her out in community supports for tenancy and sustainability, working with her on how to communicate with her property manager and how to work through some of the issues, to not necessarily become overwhelmed, but to feel supported. Eventually, she did agree to add on to her services the enhanced care management because she does have serious mental illness. She does have a long history of being homeless, and her age and conditions would have made her at risk for long-term placement without having appropriate housing. So she was approved for these services, and we started working with her to really make sure that she was supported. And the outcome of all of it is that she was able to maintain her housing. The eviction was removed. We created a plan of care for her that included her being able to have access to housekeeping, access to supports for mental health, and supports with knowing that she has a middle person to help her communicate her concerns about her housing. And so this is huge, especially in a population such as the aging that does not have a lot of support structure to make sure that they have these services in their community. So if we could move to the next slide. What the data also shows is that even though that is the story for one member, that story is duplicated time and time and time again. So as you can see, the contracts administered for enhanced care management is approximately 1.7 thousand, and those in community supports is 1.9 thousand. So if you really think about how we were able to work with one member, that one member is just one story, whereas what we have in members being served is 140.9 thousand ECM members being served and 75.8 thousand community support members being served. And so that is just multiple times over of members that are being supported with very similar stories and very similar outcomes. So the most utilized services that we do seem to find are those that are at risk for avoidable emergency room departments, and serious mental illness or substance abuse disorders, and those experiencing homelessness. And then within community supports, the most utilized services are housing transition, medically tailored meals, and housing tenancy. And if we could go to the next slide. And that's it for me. Well, thank you, Alexis.
Thank you so incredibly much, Terry. I really just want to emphasize the data that you just covered. You were able to provide this story of a member that your organization was able to support as a CS and ECM provider, community supports and enhanced care management, as a result of your team contracting with a managed care plan to render CalAIM services and benefits. That was the story of one individual. But when we look at the data from the last year of implementation, we see that there have been over 100,000 cases, of members that have been served with and connected with social service providers, so that way they can receive whole person care. And so the impact of this initiative it's palpable, it's clear. But as we move into the next section, we also need to emphasize that with any program in its infancy, despite how critical the services are, despite how valuable the impact is, there are going to be challenges within its infancy. And so because of that, especially one of this size, I am personally going to discuss some of those challenges and interventions because this work matters and these lessons are being uplifted to make sure that other states and systems can prepare for these challenges and understand the lessons that we've taken away from this work and really start to implement their own interventions. And so if we move into the next slide, I want to start us off by just discussing the core domains of challenges that we were faced with over the past couple of years. The two specific areas of concentration pertain to contracting. How do community-based organizations and other providers join the CalAIM network? And then what happens after contracting, which is implementation? What challenges are faced once services are being rendered? And so to provide some important context, at the onset of CalAIM, there were a lot of organizations expressing a very strong interest and wanting to join this thing called CalAIM, this Medicaid transformation. As Nye and Terry both mentioned, this expansion of services presented by CalAIM called for bringing in non-traditional organizations that have experience in rendering social services. However, they had never participated in Medi-Cal. They had never participated in Medicaid billing, and they didn't have existing relationships with managed care plans. So because of that, we theorized that those organizations that employ a community-based workforce, they were going to face challenges when trying to partner with plans. And so that's the first domain of challenges that we experienced. The second domain pertaining to that implementation side, as I stated above, with any program in its infancy, new providers are going to unveil unforeseen and emergent challenges within the implementation of services when fulfilling these CalAIM contracts. Some of those challenges include low member awareness that was impacting the utilization of services, administrative burden, lack of financial costing experience, so that way they could negotiate sustainable rates and contracts. We saw data sharing challenges, and we also saw a lack of clarity on providers understanding who their partners are in the provider network. And so all of that being said, if we go to the next slide, we want to discuss the interventions and the lessons that came out of those interventions. So once again, starting with the contracting side, how do we start to mediate some of these challenges that are being faced with these providers just trying to join the Medi-Cal transformation network? So we were funded by the California Healthcare Foundation to design an intervention to increase contracting readiness. How do we make sure providers understand this language so that way they can know how to contract? How can they understand the requirements? So on and so forth. And so for the model, we partnered with Aurora Health Group and Transform Health and four managed care plans to conduct 26 technical assistance sessions over the course of 15 months. And we were able to secure 1,200 attendees. And that really showed there was an appetite for social service providers to want to partner with healthcare organizations to provide these critical services. The outcomes of that intervention were 95% of our participants, they stated that they had an improved understanding of the contracting requirements. So that way they can make a well-informed decision as to whether or not they wanted to join the network. And the lessons that we were able to receive from that experience were critical. First, we learned that relationship building is key. This pertains to the relationships between plans and their peers. And also, this pertains to the relationships with providers and plans, and also between peers. So that way they can understand the service landscape and who their referral partners are. We also were able to learn that providers need support with understanding the cost of being a provider. So that way they can negotiate sustainable rates. We also learned that providers needed upfront funding, i.e. seed money, so that way they could launch their programs and build their teams. They needed to have support with absorbing some of that upfront cost. And then also, we have to be honest about the fact that transition to Medicaid billing is very hard. And these organizations have been historically grant funded. So transitioning to Medicaid billing was a hurdle. And that's what also made that that upfront funding so important, so that way they could build out their billing systems and new infrastructure. And so these are some of the lessons that we took away from contracting. When we move on to implementation, we were able to receive funding from the Department of Healthcare Services. They funded a regional technical assistance collaborative across the entire state. And if we, sorry, go to the next slide. For part two, perfect, right here. The DHCS, the Department of Healthcare Services, they funded regional technical assistance collaboratives across the entire state. And the purpose of these collaboratives was for us to convene CalAIM stakeholders, understand implementation challenges, and really start to build out those resolution strategies, with the ultimate goal of improving implementation and driving the utilization of services. We want to make sure that members know what services are available and that providers can actually render services in a more streamlined way, a more streamlined approach. And so the outcomes, even though this initiative, this technical assistance initiative, is still under progress right now, midpoint data from one region revealed to us that 83% of participants were able to gain a stronger connection to their key regional partners. That's critical for building out referral pipelines. And also 80% were able to identify an improvement practice via this technical assistance, via this collaborative experience. They're able to build out workflows that streamline implementation. And so that's key. Some of the lessons that came out of the implementation technical assistance is, number one, consumer engagement has to begin before implementation, and that's what's going to support driving utilization. Once again, going back to the challenge of low member awareness, the engagement part has to begin before services launch. Number two, standardization of referral authorizations and claim processes is key. A lot of providers face a lot of administrative burden upfront, and we can reduce that by standardizing processes, therefore allowing them to do more serving and less paper pushing. That is incredibly important, standardization. And number three, hub models should be strongly considered in order to allow smaller organizations to scale. Small CBOs that only have 5 staff, 10 staff, they need to have a central hub that can really support them, once again, with referrals, authorizations, claims. So that way they can scale their services, they can add on new programs, and they can focus on serving their community members. And all of that being stated, I'm glad that the audience now has a better understanding of the context of CalAIM, its goals, the initiatives, the successes that have come out of this work, and importantly, some of the challenges and interventions that we've all worked to implement to make sure that this program is sustainable. And on that sustainability touch point, I really want to pass it over to John, on the next slide. For John, as an FQHC and a provider in this space, to really discuss, and talk to us about how we can ensure the sustainability of all of the efforts that we've taken to stand up, CalAIM. How do we make sure that we are advancing its sustainability, that we're ensuring its success, and how do we build lasting relationships? That being said, I'll pass it over to John to, really dive into sustainability.
Yeah, thank you so much, Alexis, for this opportunity to speak about the CalAIM initiative, ECM and CS particularly. We are an FQHC here in San Joaquin County, and we've been providing ECM and CS services for the last 2 years. And so I want to be able to talk a little bit more about how we were able to sustain this and be able to scale this up. So the main thing is we have to be breaking down silos, which is a core component of the sustainability of this Medi-Cal transformation. Providers must operate as peers and not just competitors, meaning that we must leave all of our egos at the door in order to serve our Medi-Cal members. And prior to CalAIM and prior to COVID, everybody out there in our community were competitors. We did not work well together, the medical organizations. But once CalAIM came across and also COVID, we all had to work together for the benefit of our community and for the people at the most at risk. And so this right here was, like I said, very transformative, because we were able to get all these different organizations involved in helping people stabilize and then, get into housing and then also stabilize their medical conditions. So the first key component is identify your partners. And so in order to establish key relationships and to advance your referral pipelines, you must identify local stakeholders. And so, like I said earlier, we had to make those connections with different community-based organizations and county agencies to be able to assist our clients in the best way possible. We have to understand what services the key players are out there, what they offer and who they serve. And then we have to connect with the primary point of contact with them. So that was our first goal when we first started this a couple of years back. The second is advance the relationship. So after establishing those connections, we have to share information about our organizations with these new partners to ensure local stakeholders understand what our organizations are offering. One thing that's key is that I have to know who I'm referring to for my client to be able to understand what they're going to be assisting them with, and vice versa. The other agencies out there have to know what my expertises are in helping our clients stabilize as much as possible. And then the second point to that is work to advance those relationships by understanding your partner's needs and referring to those organizations. I can't help my fellow organizations out there in the community succeed if I don't know what their needs are or where their goals are. So we have to have those really good in-depth conversations to be able to move forward with ECM and CS. And lastly, as a psychologist, one thing that I've always learned is consult, consult, consult. I don't know everything. And there's people out there that are experts and people out there that have real world experience in working with the population that we serve. So you always have to consult. So this means being willing to provide knowledge, being open to receiving that knowledge, and understanding that we're all working in partnership for the betterment of our clients. And after knowing who our partners are and working to advance these important relationships, you will have more partners to consult with than you not have all of the answers. I apologize for that, but in actuality, the more people I have to be able to consult with, the more answers I can get in helping our like-minded clients. Next slide, please. So in regards to sustainability, when we started this program a couple of years back, we did not have the staffing or the infrastructure in place. So the state DHCS and our managed care plan said, hey, we would like to help you make that happen. And how are we going to be able to help you? So the first thing we did, we need initial startup cost funding for staffing, for infrastructure, for capacity building, for scaling up our systems. So the first one I want to discuss is Pass Cited, which is Providing Access and Transforming Health Initiative. So this is a 5-year, $1.85 billion initiative with 5 programs that it was funding. And these funds are dispersed directly to the stakeholders and prioritize capacity and infrastructure. So at SJ Health Centers, we went into Pass Cited and asked for initial funding for staffing, for social workers, for lead social workers, for nurses, for outreach workers. We utilize that initial funding to start to scale up our staffing, and then also ask for the initial funding for the infrastructure in regards to electronic health records and data collecting. And then secondarily, there's also IPP, which is the Incentive Payment Program. And these funds were actually dispersed to us from the managed care plans to support the implementation of CalAIM by building sustainable infrastructure, including technology and workforce, promoting equity, quality, and creating equitable access. The one thing that I want to emphasize is that there is no double dipping. So if you're asking for certain funds for staffing through PATH, you cannot ask for the same staffing through IPP. They have to be separate, or if you're building your team, you have to emphasize that in your ask. Next question, please. Or next slide, please. My bad. DHCS, and so sustainability. So what happens next? So DHCS is asking questions, is asking stakeholders out there, what is important? How can we assist you in providing these services for CS and ECM? So there's different areas that the state and providers have asked for. So standardizing eligibility is very key. We have different populations of focus that we work with. We work with the homeless population with chronic medical conditions. We work with the high utilizers that are overutilizing our hospital systems. There are the SMI and SUD populations. So with the managed care plans, there has to be an eligibility component to it. They have to have standardized with that. So that's one key component that's come out of the discussions we've had with DHCS. Streamlining and standardizing referral and authorization process. That is very key. A lot of our community-based organizations out there want to know how to put in a referral and it to be approved in a timely fashion. So in contracting with the managed care plans, we specifically put in their timeframes where these authorizations have to be approved by, and that's anywhere between 3 to 5 business days. And so because we know that if we don't get those authorizations processed quickly, we may very well lose access to our clients because our clients are the most at risk. So this process has to be quick. Expanding provider networks and streamlining payments. That is another key component. So if we're billing and we're putting things through our electronic health record systems, we have to make sure that we are coding things correctly and getting reimbursed for those services that we're providing. That is a key component to sustainability. I can't ensure my staff to be working long-term if I cannot ensure that I'm going to be reimbursed the appropriate rates for the services I'm providing long-term. All right, and then strengthening market awareness. This is also key. You know, a lot of community-based organizations need to be informed of what services are available to them out there and what things that they can offer to better assist our clients in stabilizing. So we have to be the voice. It's not just the managed care plans, and it's not just DHCS that has to be providing the information to the masses. We have to be telling people on the ground level of the services that we provide. More than not, we get family members of people that we've helped give us calls directly saying, hey, how can I get involved in this benefit? How do I qualify for this? So this information needs to be on a ground level. And then second, improving data exchange. That is key to all of these areas. You know, we need the data to be able to understand what population that we are actually affecting, and whether that be the overutilizers, the chronically ill, the homeless, birth equity. We have to have that data that supports that we are meeting those populations and providing the necessary care to help them stabilize. Next slide, please.
Perfect. Thank you so incredibly much, John. And something that always resonates with me that you have not only uplifted today, but in various other spaces, is that this is a time for us to act as partners, not competitors. In order for this to work, providers, social service organizations, various landscape stakeholders have to coordinate in order to advance care. And I think that it's such an excellent segue to one of the questions that actually just got dropped in the chat. So as we transition from all of the insights and all of the lessons that were just taken out of our panelists for today, I want to do a quick recap before we actually make that transition into the Q&A. Starting with Nye, she really did all of the level setting, really allowing us to understand the context of CalAIM, its goals, how it advances health equity, and what it takes to build those successful partnerships in order to advance health and health-related, or the advancements of health and health-related needs. Next, we heard successes and a very specific success story from Terry and data from the first year of implementation that really expands upon the reach of these programs. I was able to discuss some of the challenges and interventions that were put forward, and John really took it home with really identifying that relationships and funding are going to be key to sustaining these programs. With all of that being said, John, I really want to build upon what you were saying about, you know, providers needing to coordinate and really serve as partners in this space. The specific question that we received in the chat says, all organizations in this field should act like John, but typically they don't. What did CalAIM do that changed this behavior? Was it that providers are being paid to collaborate? And so I'm going to open up to our panelists. Anyone that wants to take on that question, you know, how did CalAIM really change the behavior of providers coordinating really to advance this initiative?
Well, I'll answer that. I think I segued a little bit into it earlier. It was a combination of both COVID and CalAIM coming together basically at the same time, where communities had to come together for the benefit of the like clients that we all work with. You know, a client that I have enrolled in my program may very well be going through an emergency room with another organization. And they need to know what services that we are currently providing for that client that went through their emergency room. And so we had to break down those silos to work with other organizations for the betterment of our like-minded clients and for the betterment of the community. And then you also alluded to the two. There's also a financial aspect of it also. For providing the services, there has to be some type of reimbursement for the services that we're providing to help our clients stabilize. So a combination of all of that has worked really, really well for San Joaquin County, because all of our agencies and different medical organizations, we have all come together to promote ECM and CS. We all work together, whether it be public health, behavioral health services, whether it be other community medical centers, whether it be transportation companies, medically tailored meal organizations. We've all come together to help stabilize our community as much as possible. So I think there was a culmination of two things, or three actually.
Yeah, and I also like to add that providers and health plans receive significant amount of support through the collaborative planning and implementation organizations such as Health Begins in Stanislaus and San Joaquin region, and there are other organizations that are doing the same in other counties as well. They actually served as a forum. They facilitated meetings, convenings for contracted providers, and those who are interested in learning more or eventually becoming a provider to these monthly calls, so that they can, number one, get information around CalAIM, any updates from California Department of Healthcare Services. And it was really an opportunity for folks to network. Now, Zoom meetings were fantastic initially, especially during the pandemic. But since last year, there's been transition to more in-person meetings. And I think those forums have really accelerated the opportunity to connect and network and build that that collaborative spirit. And so I would say that has helped and contributed to working together. And then I think the other is, folks who do this work, right? They're very passionate. People do it because it's something that they believe in. And for that reason, I see a lot of case managers going above and beyond to help individuals connect with whatever services. They could be the 14 community support services, or it could be outside of that. But I also see the level of commitment that individuals that do this work put in to be able to find the resources, the agencies to ensure that individuals get the support. And so needless to say, this is not a medical model. This is more of a social services model or public health model, as you will. And so really adding those individuals with those professional and personal alignment, I think has helped in terms of making those referrals and making those connections. And that's the result of broadening the definition of provider or provider types from Department of Healthcare Services.
Thank you both so incredibly much. And transitioning to the next question, now I'm actually going to kick this question to you. It states that participation in ECM is still below where we want it to be. And it also seems to be targeting the small number of people who are at higher risk. But should it also help those who are approaching risk? So based upon that specific feedback, do you think that CalAIM is working as it should? And how could it work better?
So thank you so much for that question. That's really a good question. I would say that we're, again, only a little over 2 years into this program. And I have to say that we've done so much in those 2 years. I mean, the level and the acceleration of which health plans and providers have come together to build a network is phenomenal. I've been in managed care since 1990s when Medi-Cal managed care first were implemented, and it took good 10, 20, and it's still improving, right? And so I would say that things are working. I know that many of us are impatient. They want to see things to be perfect, things to work well, efficiently, and it's going to take some time, right? It's going to take more than 2, 3, 4 years for us to kind of get to a place where we feel like things are working smoothly. So I would say, I'm just calling that out as a way of setting our expectations. But I think in terms of those individuals, additional individuals that should be receiving enhanced care management services and community support services, we need to find them. Health plans historically have provided a list of eligible individuals for the enhanced case management services. And that's based upon data, claims data, and algorithm, like requirements from the state. And that list, even if it's 100, unfortunately has outdated phone number and outdated addresses. And so at best, you might get third of that 100 individuals or 30 of that individuals with accurate information. And assuming that you're able to reach them and talk to them and they express interest in enrolling, we're talking about a small population. So this is why for community-based organizations, agencies that work in the community where Medi-Cal beneficiaries are receiving other services and maybe not healthcare services are critical in terms of being that conduit for that outreach, right? Especially shelters as a perfect example. My guess is that 95, if not all of those individuals are eligible for Medi-Cal benefits. And so those organizations really can be conduit in not only identifying individuals, but really they have the trust of folks that they're serving, right? And so there's an opportunity there to promote, educate, and also try to enroll those individuals into both ECM services and then refer them to community support services. And so I think there's a huge opportunity there. I think those that are working for those nonprofits understand that, but there might be some bandwidth issues, right? Because when you're working for a nonprofit, you only have so many hours and large number of clients. So there could be some opportunity there for some sort of reimbursement to help identify and to conduct that outreach and education. And then Alexis, you were asking about going upstream. Again, with ECM or enhanced case management services, it's defined and very specific from State Department of Healthcare Services. And so, for the time being, right, we have a defined population, but, as a program evolves, there could be an opportunity to identify individuals who might potentially be at risk of ultimately being eligible for ECM or enhanced care management services to be considered. But again, we're a little over 2 years into the program. There are lots of opportunities there. We're learning every month. And so, I'm very optimistic that we can go upstream at some point.
And I really appreciate your reflection on the fact that this program is only 2 years into the initiative, and that's why sharing these insights is critically important to make sure that others can start to get ahead of the curve based on the lessons that we're garnering from this experience. We are reaching time with our Q&A. And so this might be the last question we're able to fit in. And I'm going to kick this off to Terry because we have an excellent question about referrals, because we've already discussed that, being able to build those partnerships, one of the outcomes is also being able to establish those referrals pipelines. And so the question from the audience is, what do your participating providers use to communicate referrals, track referrals, and even referral outcomes for a closed loop referral? What is the process that's used? And so, Terry, I know that your organization has done a lot of great work with case conferencing and other modalities as well. So can you shed a little bit of insight into the processes used for referrals and how you coordinate with some of your partners to advance referrals as well?
Yeah, so for us, it's all about making the task easier, not harder, to refer a member who's needing support. So we took the information that the managed care plans that we are contracted with require and applied that to a simple, straightforward form that the referring community partner could understand. I go to a lot of my partners in the community and I explain to them, especially if they're not in ECM as a provider or CS, to explain to them what does it mean on a very day-to-day basis in live in action. And so we do encourage case conferencing to help break down the siloing and make sure individuals are aware that, yes, you can refer this member direct to the provider, or you can go straight to the managed care plan. The other thing for us to make sure that we are staying on top of our members and making sure we're staying accountable as a team is keeping a spreadsheet of those that are referred to us, both from the community and from the managed care plan, because we do receive member information files. And so as we are doing that, we're regularly talking to our team about who was contacted, how were they outreached to, any issues in reaching to them. Because as we update our information, we're able to help support the managed care plan to better make access to the member. And so we really try to create an atmosphere in our partners where they know that as long as we have a release of information, we are a phone call away and we are here to support them, as well as we want to make sure that they know that we're here also for whatever they might need as far as answering questions.
Thank you so incredibly much, Terry. And we are at time for our Q&A, everyone. We did receive a lot of questions. And so what we can do is have our panelists respond to those questions in the form of a document or an email and make sure that that's added to the bottom of the slide deck. So that way all of that information and those important insights that you need for your specific organization are still being communicated. And I definitely want to thank Terry, John, and Nye for all of the lessons and insights that were shared today. All of that being said, we are going to segue to our closeout and next steps. I really want to uplift just an immense amount of appreciation for everyone that took time to join us today, including our panelists. I know everyone's at capacity, and so being able to take the time out to hear and receive insights and lessons that can benefit your communities, albeit important, is still an investment from yourselves. And so we really want to extend just an immense amount of appreciation. If we go to the next slide, we also want to uplift that we do have a webinar coming up with our own Catherine Jantz. This webinar is going to be Coding and Co-Design, Social Care and Healthcare Lessons from the Gravity Project. And so that is going to take place on Wednesday, April 3rd. And we'll also make sure that everyone has the link to register for that webinar as well. And finally, I just want to thank once again, John Cisneros, Nye Kasich, and Terry White for joining us today for this webinar. And importantly, at the end of this slide deck, we've included all of the learning resources that were included inside of today's webinar. So we uplifted a lot of data, we uplifted references to various tools and lessons. And so all of that information is linked not only throughout the slide deck, but also at the bottom of the slide deck. Importantly, I just want to once again reiterate that we're going to respond to all of those questions. We'll work with our panelists to aggregate responses, and when this slide deck is sent out, we'll attach that Q&A to the bottom of this deck just to make sure that we're practicing knowledge sharing and making sure that everyone has all of the insights they need to once again implement transformative change. That being said, thank you all so incredibly much, and definitely enjoy the rest of your afternoons.